We've all been there, right? You're leaning back in the dentist chair, staring up at the light, and you hear those words. We're just going to numb you up a little bit. It's so routine, we almost don't even think about it. But what's really happening in that moment is, well, it's a small miracle of medical precision. So, have you ever stopped to wonder how that actually works? I mean, how does a simple shot know to numb, say, your lower left molar, but not your nose or your eyelid? Well, it's not magic, and it's not guesswork. It's a highly targeted mission. And today, we're going to break down exactly how clinicians pull it off. So, here's the core challenge. You need to block pain signals in one very specific spot without shutting down the whole system. Think of it like a tiny, microscopic special ops mission. And any good mission, well, it has to start with the really good map. And that map? It's the incredibly complex network of nerves in your face. It's a superhighway of electrical signals zipping around. To block just one tiny off-ramp, a clinician has to know that entire highway system like the back of their hand. The master map, the main interstate for all the sensation in your face, is called the trigeminal nerve. This is the big one. It splits into 3 main branches, and figuring out which branch to target is the absolute first and most critical step. Let's start with branch number 1, the ophthalmic branch, or V1. This one covers your forehead, your upper eyelid, and parts of your nose. But here's the thing. Clinicians almost never target this one for anesthesia. Why? Because it runs way too close to the eye, and the risk of something going wrong is just not worth it. So it's pretty much a no-go zone. Okay, on to branch 2, the maxillary branch, or V2. Now, this is the sweet spot for a lot of dental work. It handles the middle part of your face, and most importantly, your upper teeth and gums. If you've ever had a filling on a top tooth, you can bet this was the nerve your dentist was going after. And finally, we have branch 3, the mandibular branch, or V3. This one's the most complex of the bunch. It's unique because it does 2 jobs. It's sensory, so it handles feeling for your lower teeth, chin, and lip. But it's also motor, meaning it controls the muscles you use to chew. This makes things tricky. A clinician has to be incredibly precise to numb the pain for, say, a wisdom tooth removal, without messing with your ability to move your jaw. All right, so you've got your nerve map. But a map doesn't do you much good if you don't understand the terrain. In our case, the terrain is literally your skull. The next step in this mission is to identify the physical, bony landmarks that act as signposts along the way. Now, here's a really cool detail, and it explains why numbing your top teeth feels so different from your bottom teeth. Your upper jaw, the maxilla, is actually quite porous. The bone is almost like a sponge, so anesthetic can just seep right through it. But the lower jaw, the mandible, that's a whole different beast. It's the strongest, densest bone in your skull. It's like a fortress. Anesthetic can't just soak through it, which means you need a much more precise strategy. So, to find their way around that spongy upper jaw, a clinician is basically navigating by touch. They're feeling for the ridge that holds your teeth, the roof of your mouth, but what they're really searching for is a key landmark, a tiny opening in the bone called the infraorbital foramen. Think of it as a little secret passageway that gives them the perfect entry point to the nerves of the upper jaw. For the dense lower jaw, though, dot precision has to be dialed up to 11. Here, the clinician is feeling for the vertical part of your jaw called the ramus. They're searching for a very specific target on the inside surface, the mandibular foramen. It's like a tiny hidden door. If you can hit that target, you get access to the entire nerve trunk for the whole lower side of the jaw. Okay. Map acquired, terrain scouted. So what's next in our mission briefing? The toolkit. And this isn't just any old needle and syringe. This is a specialized system where every single piece is designed for precision and safety. The core kit is basically a 3-part system. You've got the syringe, that's your delivery vehicle. You've got the needle, that's what creates the pathway to the target. And then you have the cartridge, that's the payload, the anesthetic solution itself. Each part is chosen very carefully for the specific job at hand. You know, even the thickness of the needle, the gauge, is a huge decision. A 27-gauge needle is the workhorse for a lot of these procedures. And why is that? Well, it's the perfect balance. It's thin enough to be relatively comfortable for you, the patient, but it's also strong and wide enough to deliver the anesthetic smoothly and, most importantly, safely. And putting this all together is the strict, sterile ritual. Every component is inspected and assembled just so. That little harpoon you see there, that's super important. It lets the clinician pull back on the plunger just a tiny bit before injecting. It's a quick safety check to make sure the needle isn't in a blood vessel. In just a few seconds, these simple parts become a highly specialized tool. All right, so the map is understood, the terrain is scouted, the tools are prepped and ready to go. The final piece of this whole puzzle is deciding on the strategy, the actual plan of attack. And for the most part, it boils down to two main approaches. The choice comes down to these two strategies. First, you have infiltration. Think of this as the sniper approach. It's for a small, localized area, like numbing just one tooth. You put the anesthetic right where you need it, and it soaks in. The other option is a nerve block. This is more like taking out a regional power station. You target the main nerve trunk to numb an entire section of the jaw. It's way more powerful, but it's also more complex. So let's put this into practice. Let's say you just need a small filling on one of your upper teeth. The bone is spongy, the target is small. The obvious choice? Infiltration. A simple, low-risk injection right above that tooth. Quick, easy, job done. But what if you need a root canal on a lower molar? Now it's a different game. The bone is dense, the procedure is major. Infiltration just isn't going to cut it. The only way to get the job done is with a nerve block, aiming for that tiny hidden door, the mandibular foramen, to numb that entire side of the jaw. And it all comes down to this. That so-called simple numbing shot is anything but simple. It's this lightning-fast sequence of decisions, a mission plan that gets executed in just a few moments, all based on a really deep understanding of anatomy, of the tools, and of the technique. It's just an amazing reminder of the incredible science that's hidden inside our most routine procedures. It really makes you wonder, doesn't it? What other simple procedures that we take for granted are actually incredible feats of hidden science, just waiting for us to notice? Something to chew on, no pun intended, next time you're in that chair. Thanks for digging into this explainer with me.